Well, welcome everybody, and thank you for joining us this afternoon for this live CME social media event, A Splash with MASH. We're excited to be here, and thank you for joining wherever you're coming in today to talk about metabolic dysfunction, steatohepatitis. There is a change to the nomenclature. What we historically have known as NASH has now become metabolic dysfunction-associated steatotic liver disease, or FAASLD. And really the consensus around this is by identifying a patient with at least one cardiometabolic risk factor. And in doing so, we can get patients identified and reduce the stigmatization that was surrounding the prior name of NASH. So with this new criteria, new diagnostic criteria, we can get these patients identified sooner using these cardiometabolic risk factors. So again, thank you to Medscape for having us as faculty on this afternoon. My name is Christina Hanson. I'm a family nurse practitioner at South Denver Gastroenterology here in Denver, Colorado. I've been practicing for a little over 17 years in GI and hepatology. And I'm flanked by esteemed faculty, Dr. Abdelmalek and Dr. Alkhouri, who I'm going to go ahead and hand over to introduce themselves, starting with Dr. Abdelmalek.
Hello, everyone. Delighted that you can join us today. I am Manal Abdelmalek. I'm a professor of medicine here at the Mayo Clinic in Rochester, Minnesota. And I've dedicated the majority of my career to managing and caring and evaluating and investigating patients with FAASLD, and I lead clinical research here at the Mayo Clinic.
And I'm Dr. Naim Alkhouri. I'm the Chief Medical Officer and the Director of the Steatotic Liver Program at Arizona Liver Health in Phoenix, Arizona. I've been involved in research in FAASLD and MASH since 2008, and these are very exciting times with the approval of the first MASH drug by the FDA on March 14, and also the development of non-invasive tests that can help us risk stratify patients without the need for invasive liver biopsy. So I'm thrilled to be with you guys today. Let's have fun and educate our colleagues about all the new developments in the field.
Yeah, fantastic. I think the three of us can all agree it's a very exciting time for the field and for the space of MASH, certainly. And one thing, just as a housekeeping, I want to invite anyone online to go ahead and just give a shout out. Let us know where you're coming on from. Also, go ahead and put any comments as well as questions in the chat or in the comment. We're going to circle around at the end and come back to that. But we also just want to know where you're coming in from today. Next slide, please. So meet our patient for the afternoon. This is going to be a very typical patient that you're going to be seeing coming into your office, presenting in the primary care, endocrinology, being referred in to the GI practices. We see it's a 55-year-old male patient with type 2 diabetes. We know there's at least one metabolic condition. Hemoglobin A1C, 8.5%, clearly not well controlled. We need to do a little work on that. And here's some basic lab results. We see he's got elevation of his transaminases, 68 AST and ALT of 79, normal platelets, and then a FIB-4, 1.96. We're going to talk about these values in the next slide, notably the fibrosis assessment slide on this FIB-4 and what that is looking at. Actually, before we go to the next slide, let me just also point out this FIB-4, and we're going to learn in the next slide, is kind of in the indeterminate range. So this patient was sent on for a secondary assessment of fibrosis with elastography. So we assume probably a fibroscan, and we see a kilopascal reading of 11, a controlled attenuation parameter of 320. So we know this patient has severe fatty infiltration. And on the next slide, we're going to talk about this liver stiffness measurement. So now let's go to the next slide. So this slide is looking at the different ways of risk stratification, assessing fibrosis in our patient population. And there's three different types of non-invasive tests, or what we know as NITs, showcased on this slide. But we know there are many others around this. But initially, that FIB-4 score we saw on the slide before of 1.96. So the FIB-4 score is an easy calculation. You can plug this into the computer. You can plug it into your phone. easy to do. A lot of times you already have this blood work, primary care, annual exam, lab work. You don't really have to go out of your way. You have the age, AST, ALT, and a platelet count, and you can get this score. We see that on the bottom below, this less than 1.3 falls into a category of absence of advanced fibrosis. So this is something where you can have a FIB-4 as your initial triage in the primary care setting, endocrinology clinic. And really, if it's less than 1.3, you think about continuing to monitor that patient. Repeat a non-invasive test periodically. But this is a patient where maybe you can hold on to in the primary care, continuing to treat those comorbid conditions of the metabolic syndrome. If you're getting into a range of equal to or greater than 2.67, we see in red here, this can be indicative of presence of advanced fibrosis. And in that patient population, this is where you really want to be referring on to specialty care, to that liver specialist for further evaluation. And then there's a fairly broad indeterminate range. And again, this is where our patient from the slide before falls into with that FIB-4 score. And still we want to take that patient and get additional information. This is where we really want to do a secondary non-invasive test or go ahead and refer to that liver specialist. And I would err on the latter, getting that patient into a hepatologist, a specialist to go ahead and further evaluate. We know that our patient did get a fibroscan, elastography technique, and we see over here on the right, the lower right, fibroscan. It uses elastography to assess liver stiffness, which increases with fibrosis severity. It's a propagated wave that goes through the liver, and the faster or slower that wave travels through the liver, the more or less stiffness or scarring it gives us a score. And we can see the differentiators here. Less than 8 is early or no fibrosis there on the left in that green. So we're going to continue to hang on to that patient and periodically repeat non-invasive testing. If we're looking at greater than or equal to 12, that's where we're getting concerned about the presence of advanced fibrosis and even cirrhosis as those numbers increase. And then again, there's that moderate range in between. And if we remember, our patient did have a fibrosis, a fibroscan score, kilopascal score of 11. So he's definitely falling into that moderate and high moderate area of fibrosis. And the last non-invasive test I'll reference is the ELF score, Enhanced Liver Fibrosis Test. It's a proprietary test combining 3 biomarkers to assess fibrosis. And again, you can see kind of those reference ranges, less than 7.7, early or no fibrosis with a sensitivity of about 85%, meaning that about 15% of patients with advanced fibrosis might be missed in that pocket. And then if you're looking at greater than or equal to 9.8, that's giving you an idea of presence of advanced fibrosis with specificity of 90%, meaning perhaps 10% of patients are wrongly diagnosed with advanced fibrosis. And then you have that larger, moderate or intermediate range there. So these are our 3 different types of what are dry biomarkers that we're using. There are a lot of different ones out there. We've had a lot of advances. I'd like to hand it over to Dr. Abdelmalek and Alkhouri to tell me, what are you seeing in your clinic and how are you seeing this fit into our current landscape of identifying fibrosis in these patients and when to initiate treatment?
Yeah, Christina, excellent questions. As a specialist, we're typically on the receiving end of patients who have an enrichment of metabolic syndrome. And this patient already, given his age of 55 years and the presence of diabetes, already raises a red flag in my mind as a specialist as being a high-risk individual. And then you're adding in the elevation of liver aminotransferases, which is a biochemical clue of probably the presence of steatohepatitis. And that's the strongest predictor of fibrosis. So to utilize these simple tools in primary care, I would emphasize utilizing them for their strength, for their negative predictive value. Those that you could keep, as you alluded to, but this patient is already at risk, at the very least, for moderate or advanced hepatic fibrosis, and somebody who I would love to come to me because of what we'll touch on, the evolving treatment landscape really has pertinence to identifying these patients. Well, when they do come to me, I typically know that the primary care has performed the FIT4, and I go to a second risk stratifier, utilize the point of care fiber scan, and with that 11 to 12, I'm already thinking about confirmation or confidence of chronic liver injury, probably fibrosis. Do they or don't they need a liver biopsy, and what are their therapeutic options?
Yeah, I couldn't agree. And I'm not with Dr. Abdelmalek. I think this is a patient who has type 2 diabetes, elevated AST, ALT. Now the FIB4 is more than 1.3, and the transient elastography is above 10 kilopascals. I think this would be the patient that I'm trying to identify to start pharmacologic treatment or consider for clinical trials. I think a key point to emphasize that we want to start pharmacologic treatment for patients with significant fibrosis, which is basically stage 2 or higher. So we don't want to treat too early because, potentially a lifestyle intervention is adequate and these medications are costly, and potentially the patient has to stay on the medicine for years, if not for the rest of their lives. But we don't want to also wait too late and then end up with cirrhosis when these medications, at least at this point, will not be indicated. So a key message today is that the new medications that we'll be discussing, typically they target patients with stage 2 fibrosis or higher, but without cirrhosis.
I'd like to just add one comment about the FIB4. When the initial guidance is written, they were to assess for the presence or absence of advanced hepatic fibrosis. The word indeterminate, I think now as we're gaining more experience, more validation, we could potentially substitute indeterminate for intermediate at the stage. So it may be indeterminate whether it's completely absent or the presence of cirrhosis, but I'm seeing more of a substitution as opposed to indeterminate for intermediate as we're using the word moderate.
Yeah, absolutely. We're using it moderate in other places. And, we know that none of these are perfect in and of themselves, but there's value in numbers and support. So I agree with that. Let's take that as maybe more of a moderate, intermediate, and we still want to follow that up for sure. Well, Dr. Alkhouri kind of dovetailed or teed us up for the next slide. If we can move on to that, talking about, what are the population of patients that we're going to be considering treatment. But don't forget about lifestyle and modifications, diet and lifestyle modifications. So this is just a few of the different agents that we're going to talk about in the treatment of MASH that we're going to go through over the next few slides. But again, FDA approved resmetirom, very exciting, again, for the field of MASH. There's been a bit of a MASH graveyard, or a gauntlet that, these studies have been trying to navigate over the last, decades. And it's really exciting for those of us that have been in research for MASH over the years to see this one make it to the finish line. So resmetirom is a thyroid hormone receptor beta agonist. Again, as Dr. Alkhouri said, we're using this in conjunction with diet and exercise for the treatment of our adult patient population with non-cirrhotic NASH. And this is in patients with moderate to advanced liver fibrosis. So that's stage 2 to 3. That's the population we're going to be utilizing this. We're going to avoid the use of this in patients with decompensated cirrhosis. And Dr. Alkhouri is going to take us on a deeper dive in the next slide talking about that. But before we move on, other agents in clinical trials that we're going to review today include semaglutide, a glucagon-like peptide-1 receptor agonist, efruxifermin, a long-acting fibroblast growth factor 21 analog, and lanifibranor, a pan-PPAR agonist. So I'm going to hand it over in the next slide for Dr. Alkhouri to take us through the efficacy and safety of resmetirom.
Thank you, Christina. So I would say the FDA approval of resmetirom on March 14th has been probably the biggest development in the field, at least throughout my career. This is a game changer. We actually started using this in our clinics, and it really changed the conversations that I'm having with my patients. And this historic approval was based on the Maestro-NASH phase 3 trial. This was a double-blind, randomized, placebo-controlled trial. Patients had the biopsy at baseline. They had the repeat biopsy at week 52, so 1 year of treatment. They needed to have fibrosis stage 1 to 3. But the main analysis that led to FDA approval was looking at patients with F2 and F3 fibrosis. In terms of efficacy endpoints, we had two endpoints. One was NASH resolution, which is basically a decrease in liver inflammation and hepatocellular injury. And the second one was fibrosis improvement by one stage from baseline. Patients were randomized to two doses of resmetirom, low dose 80 milligrams daily, high dose 100 milligrams daily versus placebo, again treated for 52 weeks. And for NASH resolution, with the high dose resmetirom, that was achieved in 30% compared to, roughly speaking, 10% with placebo. So about 20% delta. This was statistically significant. And then for fibrosis regression with the high dose resmetirom, it was achieved in 26% versus 14% in placebo with the 12% delta. I would say, sometimes my colleagues are looking at the percentages, but you have to understand that this is only after 1 year of treatment. The vast majority of patients did not progress in their disease. We may see some benefit with longer duration of treatment. So more to come on this, and the study is ongoing, and we will have a third liver biopsy done after 54 months of treatment. Resmetirom was well tolerated, low discontinuation rate because of adverse events. The two adverse events that happen more frequently in the resmetirom arms than the placebo arm were diarrhea in about 30% of patients. This was mild and severely, typically loose stools, started after 1 week of treatment and lasted a couple of weeks. And then nausea in about 15 to 18% of patients. And similar to diarrhea, started after the first week of treatment and lasted 2-3 weeks. And otherwise, again, the drug was well tolerated, and the vast majority of patients were able to stay on the treatment. So based on this study, there was another study called the Meister and Afford phase 3 safety trial that gave us even more safety information in additional 900 plus patients. The FDA decided to approve resmetirom. And again, this is the first FDA approved drug. This is something that we are using in our clinics now. And I think the last message here is that this is the time for primary care physicians, endocrinologists to actually screen for MASLD, make sure that they determine if they have significant fibrosis, because now we have a game-changing medication that we can utilize in clinic outside of clinical trials. With this, I'll hand it to Manal to tell us about the next drug in development that might be approved next year, hopefully.
So I think everybody's familiar with this wonderful class, the GLP-1 receptor agonist. Forerunner, of course, in this space has been semaglutide. And this class of drugs is already actually approved by the FDA, but for the indication of obesity and diabetes, and not as of yet for the indication of metabolic dysfunction-associated steatotic liver disease. However, the phase 2 trial was conducted over 72 weeks. It was double-blind, randomized, controlled trial of patients with biopsy-proven NASH, now what we know as MASH, with fibrosis stage 1 to 3. And interestingly, semaglutide at each of the doses studied, 0.1, 0.2, 0.4, had a statistically significant improvement over placebo in resolution of NASH without worsening fibrosis. The improvement in NASH, at least over the duration of the study, it did not achieve any statistically significant improvement in fibrosis, but there was a sense that it may be protective against fibrosis progression. The safety, as we know, for this class of drugs is predominantly gastrointestinal symptoms, a little stools, a little nausea early on that may dissipate somewhat with continued use, but predominantly nausea, GI-related side effects. The treatment discontinuation for these adverse events was about 7%, but 5% of placebo also discontinued. The incidence of liver-related events was comparable. Increase in gallbladder-related disorders on semaglutide, but no acute pancreatitis reported. So for those obese patients who have otherwise an indication for the use of a GLP-1, certainly in areas where access to clinical trials or access to the open enrolling phase 3 study semaglutide is not feasible, we could potentially prescribe a GLP-1 for the indications that they are otherwise approved, such as diabetes or obesity, as we wait eagerly for the completion of the ESSENCE study, the phase 3 ongoing trial, which is going to clinical endpoints.
Right. And I think on the next slide, I think we have about 5 minutes to kind of compare these last two drugs in study and then have a little time for some question and answer. So I'm actually going to pass it back to both of you to go through these two medications in clinical trial.
So lanifibranor is an interesting compound. It is a PAR agonist. It's in the class of their hormone receptors. It's an alpha, delta, gamma agonist. It was studied in the phase 2 trial, 20-week double-blind, placebo-controlled study with the inclusion of patients who had the SAF score, which enriches for more necroinflammation, more an inflammatory score as opposed to the NAS score. Tested 800 and 1,200 milligrams of lanifibranor over placebo, and there was statistically significant improvement not only in NASH resolution, but in fibrosis regression at 24 weeks. And again, with the predominant side effects here also being gastrointestinal side effects, loose stools, and very, very mild weight gain. So it's important that patients remain on diet exercise regimens for this.
And the next compound that's actually in phase 3 clinical trials now is efruxifermin. This is what we call a fibroblast growth factor 21 or FGF21. This is a hormone that we produce mainly in the liver. It has pleiotropic effects. It affects a process called de novo lipogenesis, which leads to lipid loading into the hepatocytes. It has also very potent anti-fibrotic effects. It also affects lipolysis in the adipose tissue. This was studied in a phase 2b in a trial called the Harmony trial. Patients were randomized to receive 2 doses of efruxifermin, 28 milligram weekly injection, 50 milligram weekly injection versus placebo. Patients had biopsy at baseline, biopsy after 24 weeks, so just 6 months of treatment, and then a biopsy at 96 weeks. And what we're showing you here is the data from the 24-week liver biopsy. The endpoint was improvement in fibrosis by 1 stage, and this was a very robust efficacy endpoint for this medicine, efruxifermin, because fibrosis regression happened in 40% of patients treated for only 6 months versus 20% in the placebo arm, so 20% low delta. And actually, we have more updated data now from the 96-week liver biopsy, showing that up to 75% of patients treated with the high dose of efruxifermin, 50 milligrams weekly, achieved fibrosis regression by 1 stage. So very promising agent. Also, going back to the 24-week data, the NASH resolution rate was at 76% in the high dose of efruxifermin arm. This is a weekly injection similar to semaglutide. The adverse events are also similar, typically GI adverse events, diarrhea, nausea. But overall, the majority of patients are able to continue on the treatment and very well tolerated in terms of serious adverse events. So another promising medication that we have a couple more medications that are in planning for phase 3. So there's another FGF21 called pegozafermin that showed promising data in a phase 2b trial. And then recently also there was a de novo lipogenesis inhibitor called denifanstat that is also potentially entering a phase 3. So the outline is robust. I think we will have several medications to choose from before the end of the decade. And this makes me very excited for our patients with at-risk MASH or MASH with significant fibrosis.
Mm-hmm. In the last minute or two before we move on to question and answer, I'll kind of pose to both of you, when we look at this exciting time in treating and managing MASH, we think about our patient here at the beginning of this. We see what we have recently had FDA approved and what's coming up in the pipeline. What are some last minute takeaways that both of you have as far as how we're going to be identifying these patients, which patients we want to be getting on treatment, and what that's going to look like in the future for monitoring these patients with these non-invasive tests? Any last minute thoughts for you?
And so I think my earnestness is to identify those patients at highest risk, first and foremost. that patient, at least until we get broad distribution and availability, and potentially even lower costs of these therapies, for patients with fibrosis stage 3 and fibrosis stage 2, already is at the onset. But anybody who's got fibrosis stage 2 or higher is already at risk for fibrosis progression, and that's the primary clinical outcome. So I'm going to be striving to identify those patients, see if they're eligible for resmetirom, and as the other therapies emerge, what will likely be these combination approaches push the envelope of MASH resolution and fibrosis progression beyond what we're already seeing, which is a 20% placebo-corrected resmetirom and 12% placebo-corrected response rate for fibrosis progression. I am hopeful that the story with hepatitis C, as we continue to improve and improve and improve upon treatments of hepatitis C to cure, that we'll see the same story unfold with WASH and MASH.
Yeah.
Yeah, not much to add to this, but I would say maybe one key message is if you have type 2 diabetes, make sure that you have been screened for MASLD and MASH. Ask your primary care doctor or endocrinologist. And if you've been told that you have MASLD and MASH, ask what is the state of my disease, because things are changing very fast. And I do not want to see people progress to cirrhosis on the watch of their primary care physicians and endocrinologists without, having an opportunity to receive potentially life-saving treatments that are, available today for all patients.
Okay. And I'm going to leave the last couple minutes here for some questions, but I want to make sure everybody is aware to scan that QR code to claim your CME credit. So make sure that you see that. You can also claim CME credit at medscape.org. I think we'll put that in. I'm not going to be able to tell you the whole the email or the address there, but scan in the code, or we'll put in a medscape.org link that you can access as well. Dr. Alkhouri, we've got a couple questions on our currently approved resmetirom on the mechanism of action. If you can talk a little bit about what is it doing? What's this thyroid hormone thing?
Yeah, so it mimics the effects of the thyroid hormone, but specifically within the liver. So it turns out that, thyroid hormone signals through two nuclear receptors, thyroid hormone receptor alpha, which is highly expressed in the heart, bones. So if you target this, you may induce thyrotoxicosis, arrhythmias, so we want to avoid it. And then we have thyroid hormone receptor beta, which is highly expressed in the liver. And in patients with MASLD MASH, there is a state of this, what we call relative intrahepatic hypothyroidism. So by giving them resmetirom, you restore the effects of the thyroid hormones within the liver specifically. You can decrease the process of lipid loading into the hepatocytes, the lipogenesis. And by doing this, you allow the liver to heal and you resolve inflammation and downstream fibrosis. So this is quickly the mechanism of action. So again, it's liver targeted, mimicking the effects of the thyroid hormones without causing any thyrotoxicosis.
Okay. And Dr. Abdelmalek, a question on hepcidin or FGF21 testing in the diagnosis and treatment or for follow-up in MASH?
Yeah, I haven't found that FGF21 testing per se to check serum levels really changes the need for treatment, which is based on risk stratification for the presence or absence of fibrosis. The landscape of therapy certainly may be a larger armamentarium that we have in the future, and there could be a role for prognostic testing of a predictor of treatment response in the future. As of now, I'm not testing for baseline characteristics to offer treatment. My game has changed significantly because historically I could only talk about development exercise and offer patients the opportunity to participate in these clinical trials. But now I'm having a very detailed discussion about resmetirom. And yes, I have prescribed it for that moderate to advanced outpatient with chronic fibrosis and MASH. So not only do I use lifestyle modification diet as a foundation, but therapies for those that need it as an add-on approach to minimizing their disease progression.
Yeah, and that was one of the specific questions directed at both of you as well. Your patients are happy. We're all excited about this. Have you been writing prescriptions? I know Dr. Alkhouri and I have already talked about that, but it sounds like you both have that patient population in mind. We've been waiting. It really is that F2, F3, get these patients identified and get them on treatment. in conjunction with diet and lifestyle modifications. So definitely great for the field, and we're all very excited to be a part of that. So with that, we want to thank you for your participation in this activity, and don't forget to log on or scan the QR for your CME credit. Thank you, everybody. Good night.
Thank you.